per major global guidelines like ASPN or ESPN, Canada Clinical Practice Guidelines, and other recommended initiation of the enteral feeding within 24 to 48 hours following the admission into the ICU. Early initiation decreases infectious complication, disease severity, and in turn the length of the hospital stay. There are merits of the definitions of diarrhea. However, to diagnose diarrhea, three below mentioned parameters have to be referred. First, abnormal frequency. 3 or more bowel movements per day. Regarding the abnormal consistency, a non-formed stools or with excessive water content. What is meant by excessive water content? The normal water content of the stool is 60 to 85%. If the consistency is more than 60 to 85% of the water, then it is related with the consistency. And the third is the volume. Volumes greater than 500 gram per bowel movements are abnormal. What are the reasons for diarrhea in ICU? There are so many reasons for diarrhea in ICU or hospitalized patient. The first, in severe nutrition depletion, atrophy of the gut mucosa and impairment of the pancreatic function may predispose to the severe diarrhea following oral or enteral refeeding. Thus, diarrhea is often observed in patients with hypoalbuminemia. Atrophy also occurs when oral intake is discontinued for longer period. This is commonly seen in the surgical patients advised bowel rest. Second reason for the diarrhea in ICU patients is the abnormal motility. What is meant by that? Intestinal motility is a frequent problem in ICU. The use of the prokinetic drugs like erythromycin can cause inadvertent diarrhea. Third cause of diarrhea in ICU patients is the abnormal blood flow. Systemic administration of the antibiotics alters normal ecology of the colonic lumen, possibly leading to diarrhea. Fourth one is increased mucus secretion from the large bowel. It is observed in Clostridium difficile colitis or amoebiasis. Fifth cause of the diarrhea due to the osmotic load. Medications such as sorbitol, paracetamol, diphenoxylate, furosemide, metoclopramide, multivitamin liquids, and cimetidine liquid may cause osmolar load. Typical liquids such as the milk, sodas, juices, ice creams, sarbat, hyperosmolar enteral nutrition formula may lead to diarrhea. Incomplete digestion, especially protein digestion, since majority of the ICU patients are on the H2 blockers or proton pump inhibitors, which increases the pH of the stomach, and hence protein digestion in stomach suffers. Feedings frequently bypassing the stomach also suffers from the incomplete digestion. Sixth one is the iatrogenic overfeeding. It occurs in up to 33% of the ICU patients and is a result of the inappropriate estimation of the calorie proteins. This may result in excessive load of these nutrition, eventually causing the diarrhea. 7 commonest cause of diarrhea in ICU patient is the infective diarrhea. Due to unhygienic feeding habits or improper hygiene of the surrounding may lead to the infective diarrhea. Management of diarrhea includes proper diagnosis of diarrhea becomes very important in the management of diarrhea. Causes have to be identified. Management depends on identification of the cause. The causative factor has to be eliminated, modified, or treated. Antibiotic used to treat the infective diarrhea should be cautiously used. Restoring normal colonic flora with prebiotic is recommended. Practice of stopping feed in diarrhea patient is reasonable only when the patient is overfed or if there is an intolerance to the diet. Continuing with the trickle volume continuous feed is recommended. Only very rarely it is appropriate to stop the enteral nutrition and start parenteral nutrition as a treatment of diarrhea. Common abnormality is hypernatremia. Hypernatremia is defined as serum sodium greater than 145 millimole per liter. It is commonly observed problem in up to 2% of the general hospital patient population and up to 15% of the ICU patients. In outpatient population, it is more prevalent in geriatric age group. However, it prevails equally amongst the all age groups in hospitalized patients. It can be caused by either water deficit or salt gain. Usual mechanism underlying the development of hypernatremia is inadequate water intake and increased free water loss. Thus, hypernatremia results from the deficit of the free water that leads to an increase in the serum tonicity. Hypernatremia always represents a hyperosmolar state. Absence of antidiuretic hormone secretion causing diabetes insipidus is seen in patients with pituitary tumors, traumatic brain injury patients, and in CNS infection. This might be the common reason for hypernatremia. Other common risk factors for the hypernatremia can be severe gastroenteritis, excessive use of the isotonic or hypertonic saline solutions, use of the diuretic, use of the radiological contrast material, or excessive insensible cutaneous loss. Even in diabetic ketoacidosis, we may come across the hypernatremia. Hypertonic enteral feeding formulas may be reason for hypernatremia, and use of the catheteric agents may result into the hypernatremia. Now, symptoms of the hypernatremia are generally non-specific, and they are often difficult to separate from those of the underlying illness. CNS abnormalities are more common. Initial symptoms result from the movement of the water out of the brain cells rather than hypernatremic per se. Current sodium administration practices. Sodium is ubiquitous in ICU. Virtually all flushes, feed, infusions, transfusions, and medications contain sodium. Now let's discuss management of hypernatremia in ICU. Most important is calculation of daily sodium intake and identify the amount overfed as well as probable reasons for the same. Avoiding usage of the normal saline for flushing, IV lines, catheters and Ryle's tube. Limiting sodium intake and at the same time correction of the hypernatremia needs to be initiated. Published recommendations state that the rate of correction of sodium should be less than 0.5 millimole per liter per hour or not more than 2 milliequivalent per liter per hour. Accepted goal is to correct half the water deficit over first 24 hours and the remaining to be corrected over the next 48 hours. In severe hypernatremia, the level should not be corrected to below 150 millimole per liter in the first 48 to 72 hours. Drug dilution in 5% dextrose rather than normal saline will reduce inappropriate sodium loading. It is evoked by the integral hormonal cytokine and the nervous signals on glucose metabolism pathway. In acute phase of the critical care illness, higher levels of the glucagon, cortisol and growth hormone jointly increases the hepatic gluconeogenesis. In addition, in critical ill patients, epinephrine and norepinephrine promotes the hepatic glycogenolysis. Even in acute phase of the critical illness, cytokines like interleukin 1, interleukin 6 and tumor necrotic factor may directly or indirectly enhances both of these hyperglycemic response. Glucose uptake is also challenged during the critical care illness. For example, the exercise stimulated glucose uptake disappears. As well, insulin stimulated glucose uptake is hampered because of the combined inhibition of GLUT4 dependent insulin stimulated glucose uptake or because of the glycogen synthesis activity. However, there is an increased total body glucose uptake by mononuclear phagocyte system in the liver, spleen and ileum. Despite this, there is an impaired peripheral glucose uptake and increased hepatic glucose production. This indicates insulin resistance during critical illness. Let's start discussing about the management. In acute phase critical care illness, most of our patients are on IV fluids, vasopressors like norepinephrine, epinephrine and also on ventilator support. In acute stage, it is very difficult to manage the hyperglycemia. When these patients are on high supports like a vasopressor as well as the ventilator support, even feeding is not the full. We are giving the partial enteral feeding along with the IV infusions. When these patients are on an IV infusion in an unstable condition, then we do not advocate the full enteral feeding. In this setting, to control the sugar, we advise the blood sugar every 1 hourly or 2 hourly. Control the sugar by insulin infusion pump. In these settings, we frequently monitor the BSL. We prefer to keep the sugars in between 180 to 200 In due course, when patient improves, what is meant by patient improves? When vasopressors are coming down, when ventilatory requirement is coming down, oxygen requirement is less than 60%, then we reduce the frequency of the sugar monitoring, accordingly the insulin by infusion pump, and later simultaneously we increase the enteral feeding. When patient goes on a full enteral feeding, then we prefer to keep the sugar monitoring every 4 hourly or 6 hourly and followed by the subcutaneous insulin management. Stress-induced hyperglycemia is a very common in critically ill patient. Unlike the diagnostic criteria for the diabetes mellitus, there is no clear guidelines have been set for defining hyperglycemia in critically ill patients. Evidence recommend liberal glycemic control, that is up to the 180 to 200 mg per deciliter, and beyond that continuous insulin infusion pump for controlling subsequent hyperglycemia. What are the reasons for hyperglycemia in critically ill patient? Generally it is evoked by the integrated hormonal, cytokine and the nervous signals on the glucose metabolism pathways. In acute phase of the critical care illness, the higher levels of the glucagon, cortisol and the growth hormone jointly increase the hepatic gluconeogenesis. In addition, epinephrine and norepinephrine promotes hepatic glycogenolysis. Even the cytokines like interleukin 1, interleukin 6 as well as the tumor necrotic factor may directly or indirectly enhance both these hyperglycemic response. Glucose uptake is also challenged during the critical illness. The exercise stimulated glucose uptake disappears. Even insulin stimulated glucose uptake is hampered because of the combined inhibition of the GLUT4 dependent insulin stimulated glucose uptake and glycogen synthesis activity. However, there is an increased total body glucose uptake by mononuclear phagocyte systems in liver, spleen and ileum. Despite this, there is an impaired peripheral glucose uptake and increased hepatic glucose production. This indicates insulin resistance during the critical care illness. So what is the management of hyperglycemia in critical care settings? In acute phase of critical care illness, management of hyperglycemia depends on condition of the patient. When patients are on high dose of vasopressors, also on high ventilator support, we prefer to keep the blood sugar less than or equal to 180 mg per deciliter. It is advised to do the BSL 1 hourly and titrate insulin by the infusion pump. In due course, when supports are coming down, we can reduce the frequency of the blood sugar monitoring and accordingly insulin infusion. At this phase, trickle volume enteral feeds may be initiated on the continuous basis. When patients recover and off supports, then we can start full enteral nutrition along with the insulin subcutaneously. Refeeding syndrome is defined by a group of the electrolyte changes associated with the metabolic abnormalities that can occur as a result of the nutritional support, either oral, enteral or parenteral in marginalized patients. It may appear within the first 5 days of start of feeding. Clinical features of the refeeding syndrome are abnormalities of the fluid balance, abnormal glucose metabolism, hypophosphatemia, hypomagnesemia, hypokalemia, and even vitamin deficiency. What are the probable reasons for refeeding syndrome? Aggressive nutritional support signals the body to halt its compensative mechanisms, and in turn body turns from a catabolic to anabolic state. During the refeeding, the rising glycemia leads to increase in insulin secretion and reduction in the glucagon. This process stimulates glycogen, fat and protein synthesis, which requires intracellular ions such as potassium, phosphate and magnesium. Thus, there is an insulin-dependent cellular uptake of the glucose, potassium, magnesium, phosphate and water as well as renal sodium water retention. In severe nutrition depletion, atrophy of the gut mucosa and impairment of the pancreatic function may predispose to severe diarrhea following oral or enteral refeeding, precipitating further electrolyte and mineral imbalance. Patients who are at risk of developing refeeding syndrome are the patients who has anorexia nervosa or patients who are in depression, patients who has hyperemesis or dysphagia, HIV or cancer patients, malabsorptive syndromes, bariatric surgery patients, hospitalized patients fasting for 7 to 10 days, patients who weight less than 70% of the ideal body weight. Now let's start discussing the management of refeeding syndrome in ICUs. First and the most important thing is the clinical monitoring. Clinical monitoring is the foremost. Do serum sodium, potassium, glucose, urea and creatine daily for the first week and thereafter weekly. Also serum calcium, magnesium and phosphate twice weekly during the first week and thereafter once weekly. The most important, start slow and go slow is the rule for starting nutrition. Since there is a lack of the consensus regarding the appropriate initial caloric administration in the patients at high risk of the refeeding syndrome on day 1, very low caloric intake should be provided. That means even as low as 25% of the requirements should be provided. Thus it justifies the trickle volume feeds as recommended by the international guidelines. The feeding rate can be increased gradually in next 3 to 5 days. A closed feeding system also comes with many benefits. It not only requires the less handling and nursing time, but also reduces the chances of the nosocomial and bacterial infection. By delivering the greater percentage of the patient's nutrient needs, it ensures improved nutritional status and better outcome.